And now it is time to welcome to the stage Juliana, who is going to be your host for the third and final day of the 35th Annual Caregivers Conference. Welcome, Juliana.
Thank you, Steve. And welcome to the last day of our 35th Annual Northern Virginia Dementia Care Consortium Caregivers Conference. As Steve mentioned, my name is Juliana Valencia. I am this year's NVDCC chairperson, and I will be your MC for today's virtual session. We are excited that you are joining us today, and we hope that during the last 2 days, you've learned insightful and valuable information. Next slide, please. So before we really dive into today's event, let's review a few Zoom tips to make this the best experience possible for you. First, if you look to the bottom of your screen, you will see the Zoom menu bar. And one of the options is chat, which is a great way to introduce yourself to other attendees, to share resources, to make comments about the presentation and interact with each other. It is important to know that when you click on chat, you also must choose in the drop-down menu all panelists and attendees so that everyone can see your message. Now you can minimize and maximize any window in Zoom. So if you find chat distracting, just click on that window and minimize it. Next slide, please. Q&A is a different button, which you can find on the bottom in your menu bar as well. This is how you ask questions of our speakers. So while our two speakers are presenting today, when questions come to mind, this is the perfect place to enter those questions because this is where we are going to be looking for them. Next slide, please. Also, we have closed captioning for anyone who prefers to see the written words instead of relying on audio. Next slide, please. And lastly, you can adjust your screen layout to fit preferences in the top right-hand corner of your Zoom screen. You can click the bottom to change from speaker view into gallery view or back and forth or however you prefer. Next slide, please. So this year's conference theme is Caregiving While Memories Fade. This theme reflects on the opportunities to stay connected while adapting and changing our interactions with our loved ones, whose memories fade at each stage of the disease. During this 3-day conference, our goal has been to bring you opportunities to learn, encouragement to adapt, and the confidence to thrive as a caregiver. During the past 2 days, we have had great sessions, and today's promises to be as informative and valuable as well. Next slide, please. So the Northern Virginia Dementia Care Consortium Caregivers Conference is organized each year by a committee of volunteer professionals that represent our dementia community in Northern Virginia. The consortium plans and works all year long to plan this high-quality education event. Members of the NVDCC Planning Committee are available to view on your screen. Thank you to these individuals and their organizations for the wonderful work and support. I also want to thank Steve Gurney of Positive Aging Sourcebook for all he has done to make this a great virtual experience for everyone. Now, we've been asking this question throughout the conference, and today we're also going to ask that question. As mentioned earlier, this is our 35th Annual Caregivers Conference, and we would like to hear from you. In what capacity are you attending this conference? Are you planning for your own future? Are you a family caregiver to a loved one? Are you attending as a professional or as a volunteer? So if you can take that vote, that will help us know in what capacity you are here. And while we wait, I just want to thank everyone in the audience for making the time to join us today. Thank you so much, and we hope that today is a wonderful experience for all of you. Steve, do we have any results in yet? Great. So it seems like the majority of our attendees are family caregivers. And then we have a big portion who are professionals and volunteers. And then we also have a lot of people in the audience who are planning for their own future. Well, thank you so much and welcome. I am confident that each and every one of you will find this conference to be meaningful in your caregiving role. Now, I would like to welcome my consortium colleague, Natalia Giscombe Simons, who is a retired Lieutenant Colonel of the United States Air Force. She is going to give us a special message today.
Hello, greetings to everyone. To all veterans here today, I sincerely thank you for your bravery, your service, sacrifice to our country. I share the pride you feel in being able to say you have served in this greatest military in the world. Thank you all for choosing to honor veterans today and show your support of our heroes, past and present. As a way to honor our veterans today, let us join together in a moment of silence for those who have served and those who have passed away, and for those who have served and returned back home safely, and for those who are currently serving in our country. A moment of silence, please.
Thank you so much, Natalia. That was a wonderful message.
Thank you.
Now we are very grateful to our conference sponsors for making this event possible for caregivers across Northern Virginia and beyond. Without the support of our sponsors, we would not be able to host this conference. Today's conference sponsors are AARP Virginia, Synergy Home Care, Goodwin House, ACC Family Adult Companion Care, and Graceful Care. Thank you so much for your support and for helping us making this conference possible. Next slide, please. Now, I would like to share some housekeeping pieces of information to address some frequently asked questions. Today is the last day of this year's NVDCC Caregivers Conference. Each day's session has been recorded, and you will get a link to access those recordings by the end of today. Handouts for all sessions have been posted on our website, and we are actually going to paste that link in the chat box now, so you can access that at a later time or whenever you prefer. Now, for those professional attendees wishing to apply to George Mason University for continuing education units, those professionals must attend all conference sessions. The link to access the CEUs will be provided at the end of today's sessions, and the cost is going to be $50 payable to George Mason University. So stay tuned for that link. Next slide, please. Now, one of the most valuable aspects of our Caregivers Conference is our virtual exhibit hall. And I don't know if Steve can pull up the website. Yes, thank you so much. This year, we are actually offering a virtual exhibit hall where you can explore, learn, and talk with exhibitors. And you can access our virtual exhibit hall 24/7 for the entire months of November and December. There are two ways to find the virtual exhibit hall. One of them is on our website, nvdcc.com. You can click on the virtual exhibit hall in the menu at the top of the page. And the other one is to click on the exhibit hall link that we are dropping in the chat right now. We really encourage everyone to make their way around the virtual exhibit hall. There are over 40 great resources to explore from, including videos, links to websites, social media, and much more. And I think, thank you. I think Steve had shown you how to do that. And thank you so much, Steve. Now, I would like to bring in my consortium colleague, Lindsay, who will introduce today's session.
Good morning, everyone. So glad that you can join us today for our 35th annual Caregivers Conference. Today's first session is Understanding Young-Onset Dementias by Dr. Chiadi Onyike. Dr. Onyike specializes in neuropsychiatry and focuses on the care of individuals who have neurodegenerative dementias. His practice focuses on conditions that develop in midlife or earlier, including frontotemporal dementias, young-onset Alzheimer's diseases, prion diseases, leukodystrophy, and other atypical conditions that cause cognitive and behavioral impairments and dementia. He is principal investigator or co-investigator of studies focused on the epidemiology and treatment of the frontotemporal dementias, Alzheimer's disease, Lewy body disease, spinocerebellar ataxias, and other neurodegenerative disorders. Dr. Onyike is a member of the Medical Advisory Council of the Association for Frontotemporal Degeneration, the FTD Disorders Registry Scientific Advisory Board, and the FDA Advisory Committee for Central and Peripheral Nervous System Drugs. He serves on the Alzheimer's Association's Best Clinical Practices Guidelines Work Group and has participated in the National Institute on Aging's Alzheimer's Disease and Related Dementias Workshop Committees. He is a founding member of the International Society for Frontotemporal Dementias. It is my pleasure to present to you Dr. Chiadi Onyike.
Thank you so much, Lindsay. It's a pleasure to be back. I was here last year, and I'm delighted to be back. I want to thank everyone involved for inviting me, for putting together this conference. It's very important that we communicate what we know to the people who live with these conditions, with conditions that cause dementia. I'm going to share my slides now. I want to mention that I have an annoying vent above me. So if you hear a blowing sound, that's what that is. Not been able to fix it. I've tried to adjust the sound and everything. So bear with me, but I hope you can hear me clearly. And if you can't, now would be the time to say so that we can raise our voice a bit more. I'm going to be talking about young-onset dementias. And before I begin, I want to point out that I've been involved in, as a lead investigator or a co-investigator, in a variety of studies pertaining to dementia, to Alzheimer's disease, to frontotemporal dementia, to dementia with Lewy bodies and other conditions. Some of these are sponsored by industry, and some of those results have been published. I will talk about prescribing medicines in brief. And when I do so, it's important to understand that that's not based on FDA labeling. It's based on experience. It's based on research. Now, young-onset dementia is defined primarily by the age group that is affected. So typically, when people think of dementia, of Alzheimer's disease, for example, they think in terms of something that affects elders. People who are 65 and older, but it can come. There are reasons to conceptualize it differently. So there are reasons to think in terms of dementia that's affecting a typical age group, which would be about 65 to 80. Dementia that's arising in the oldest old, as some people will call it, which usually is dementia that's developing when people are 85 and older. And surprisingly, we're discovering that in this oldest age group, a substantial proportion of dementia that arises that late is not Alzheimer's disease. And then in the young onset, and then there's a group, which is the group we'll be focusing on today, who develop dementia in midlife or earlier, sometimes in adulthood, sometimes as early as in their late 20s, early 30s. Now, there are differences in terms of how this manifests. There are differences in terms of the genetics and in terms of the pathological finding you'll see when one examines the brain. These differences, particularly those pertaining to how it presents, how it manifests, are important to recognize, because that's how diagnosis becomes efficient. That's how care becomes effective, becomes resonant. And there is research that's going into all of this to clarify the needs and to articulate different kinds of interventions, pharmacologic interventions and other kinds of interventions, and how they apply specifically to people who have young onset dementias. And I'd like to begin, to illustrate how dementias in younger people might manifest, I'm going to begin with this vignette. This was a technician of 55. I first saw him about 10 years ago. May have been over 10 years ago. He was 55 at the time problems began. He had trouble finding words. Then his speech became disfluent, so hesitations. He became repetitious, but it wasn't on account of forgetting. It was the repetitiousness that you might, for example, that many of you might have observed in children, for example, where they ask the same question over and over. He also had stereotypies, or what we call habits, that in this case were annoying. For example, banging on the table, or stamping his foot, or clapping. And he had what we call echolalia, which is basically mindlessly repeating what people say, word for word. Now, in the second year of his illness, it was no longer possible for him to work, so he went off on disability. At that point, he was very childlike. He was impulsive. He was indifferent to how others feel, so he was egocentric, if you will. He insisted on watching the same TV shows, and sometimes he'd watch over and over the same episode. He'd interrupt family when they were watching something else to watch what he wanted to watch. So his manners had declined. He was intruding also on strangers. He was eating. When the table was laid, for example, he'd reach into the serving bowl and eat from there. When they were out, say in the grocery store, he'd jump the queue. He'd walk right to the front of the queue. People might be talking to him and he'd suddenly walk away. He was very restless as well. So he was biking, he was swimming, he was running every day. And especially because of that restlessness, his wife decided to set up his volunteering, and that was a good way to. That was the term we used, volunteering. He was attached to his maintenance crew at a local residential care facility, and so he'd just follow them, and they'll hand him off shift to shift until his wife could take him home. So when I saw him, he was in year 3 or 4 of this illness. And at that point, he was pleasant. So there was no evidence that he had depression. He wasn't anxious. He wasn't euphoric. There was no mania. He wasn't psychotic. He didn't have hallucinations. He wasn't paranoid. As I mentioned, his speech was a little. There were hesitations, occasional stutter, but the grammar was correct. It was complete. And his mini mental state exam score was 29. So for those of us, and I think most of us here are probably familiar with the MMSE. A 29 score is just 1 point short of a perfect score. And if you were in front of a primary physician who's not the wiser, they would say, oh no, he doesn't have dementia, he can't have dementia, his mini mental state exam score is high. And they would be forgetting that when we are asking questions in the mini mental state exam score, we're not asking sophisticated questions. We're not asking about, for example, who the governor is, or what the current administration's plans are for a certain topic. So it's a low ceiling, and people can decline substantially, and depending on the context, still attain a perfect or near perfect score. His brain MRI scan showed shrinkage in a particular region of the brain. So here I describe it as right temporal atrophy, and I will show you some images so that you get a better sense of what that means. A year later, he had now developed a preference for sweets, and he was overeating, and he was foraging. So he would search high and low for food, eating everything in sight. And he was admitted to residential care at about this point. Now, in residential care, in the preparations to residential care, we had conversations with the residential facility and look his memory, and they said, oh yeah, we know. We have a good memory disorders unit, and we said, his memory is fine. These are the issues, and they were confident they could take care of him. It was a week or 2, maybe 3, into his stay in the residential care when he waited for the nurse's station to be empty, stole a nurse's car keys and her wallet, or purse rather, punched the code to get out, and drove her car to go buy ice cream. And then he returned. So this is misbehavior, but it isn't forgetting. He didn't forget. He didn't have trouble finding his way. He didn't even have trouble making plans. They were just inappropriate plans. And this is the hallmark of what we would call behavioral frontotemporal dementia. And at that point, he still had a very high mini mental state exam score. So here's a person where the hallmarks of dysfunction are not about memory, they're not about orientation, and instead they're mainly about the coarsening of his dispositions, of his judgment, of his comportment, the loss of the ability to properly control emotions and drives, for example, hunger. And in his case, the disintegration of language and communication, in his case, not too advanced at the point. So it was rather mild. So frontotemporal dementias, which are a major type of young onset dementia, are characterized by a behavioral phenotype where there are combinations of indifference, impatience, carelessness, jocularity, insensitivity, distractibility, impulsiveness, stereotype behaviors, compulsions, and rigid. Basically, all the things that either our parents or teachers or others who are in a nurturing role have tried to train us to not be. So it's basically a loss of basic social knowledge and understanding and control. Now, sometimes it's instead dominated by language problems, in which case the speech is effortful, disfluent, agrammatical, much worse than what I've described for this particular person, or it is fluent, but they're not really saying anything, and that's because they're losing knowledge of what words are or mean, and they're losing knowledge of what objects are or mean. And so you can imagine that if you're having a conversation with someone who doesn't use any nouns, you'll have no idea what they're talking about, even though you'll understand the speech in terms of the grammar. Now, here's another person, similar, lapses in judgment and aloofness, as well as poor self-control were the beginnings of it. And examples of her poor self-control where she'd laugh in public, unexpectedly and too boisterously, and in situations where it was unwarranted. She approached a vagrant. She told him he had bad teeth. She sometimes will engage in racial talk, and it wasn't because she had been prejudiced before. It was new. She would dance exuberantly in public. She also engaged in the same childlike repetitiousness that I described previously. She was repeatedly buying groceries, even when reminded that everything was there. Even when on the way out she was shown that there were groceries in the house, she'd still go out and do it and buy. She had to leave work. She was able to maintain her hygiene. She had restless legs during sleep, and also was sleeping too much. And when family were out with her, she'd have a tendency to wander off. So you can imagine when you're, let's say you're out at a county fair or something, and you have a child at a certain age, you have to hold on to your child because they're not paying attention to you as a family walking together. They are liable to just wander off on their own, and that's the kind of thing she was doing. She was also doing these stereotypies that I described before: fidgeting, rubbing her fingers, tapping her legs, banging on tables, clapping, and so on. And her mental state exam score was also quite high. It was 28. But in her case, the Ftg Pet Scan showed reduced uptake of the tracer in the frontal lobe. So her MRI was normal, and that's why we got an Fdg Pet. And I'm going to illustrate later how I'll explain better what these different kinds of scans are and how they inform the diagnostic process. But there's another reason. It wasn't merely to drive home the point of a behavioral dementia, but there's a second reason that I chose this vignette, and that's because in this case there was a family history, and here's the pedigree. And so you can see the arrow at the bottom. That is the patient I just described. And at the time I saw her first cousin was still living. So this cousin died soon after I saw her, and she hadn't had a proper diagnosis, so she was in Nebraska. And so what I did was I interviewed the family, got the details of what had happened, how she had come to be where she was, and we had the opportunity to examine her brain. And based on that brain examination, we ordered genetic testing, and we were able to find out the genetic cause, the reason why all these members of her family had developed the condition. Now, it turns out that in the last year, this cousin has also developed symptoms. So I mentioned earlier that genetics is important in young onset dementias, and that's because a higher proportion of people with young onset dementias reaching up to 20% of young-onset dementias are hereditary. And that's in contrast to, say, when dementia begins after age 65, where it's well below 5%. Now, it's not the majority. So there is an idea out there that most young-onset dementia is hereditary. That is not true. But a large proportion, larger than what you would expect for typical Alzheimer's disease or typical late-life dementia, is hereditary. Now, with Alzheimer's disease, and I should mention that the initial case that Alois Alzheimer examined, the very first patient he examined, August Dieter, was 51, and it was her story and the examination of her brain, that it was from her story and her examination of the brain that he described what would be called Alzheimer's disease to this day. This is not her brain, but it illustrates what you'd find in Alzheimer's disease. So shrinkage all around. So these spaces that you see here are wider and ordinarily should be tightly packed. And here you see something that's a deposit that's out. You see these deposits that are outside of the cells. So here are the cells, for example. This is outside the cells, but around the cells. And this is what we call a plaque. It's made of amyloid protein, and that's a word that you should remember, amyloid, because we'll come back to it. Now here you have a tangle. So this is a cell. Now the tangles are within the cells. And what you have here is basically clumping of tau protein. So that's another thing that we should remember, tau. So amyloid and tau together make up Alzheimer's disease. So when this is more like a bird's eye view where you can see plaques and tangles, these things that look like tadpoles. And these together are what pathologically define Alzheimer's disease. And until recently, a definitive diagnosis of Alzheimer's disease would have been based on seeing this in the brain, except that we would typically do that as a post-mortem examination rather than getting a brain biopsy during life. Every case of Alzheimer's disease will have these features in the brain. Now that's in contrast. So here's a contrast. In frontotemporal dementia, as you can see, there's a distinction to be made. In fact, you could draw a line here, which is what we call knife edge atrophy. The idea that there's a sharp demarcation between what is abnormal. You can see the difference even in the size of the gyri here versus there. So the frontal lobes here, this is the frontal lobe, is shriveled relative to, say, the parietal lobe, which would be this region, the occipital lobe, which is that all the way at the back, or the temporal lobe, which is here underneath. So this is the classical finding that for frontotemporal dementia, first described by Arnold Pick in the early 1890s. Now, Arnold Pick also identified what we call Pick bodies. That's in panel A. These are composed of tau protein. So you remember tau. Now, in frontotemporal dementia, in contrast to Alzheimer's disease, you don't have a single unifying pathology. Instead, from case to case, there are differences. There are differences in how the syndrome looks, so in what the clinical features are. So it could be behavioral, it could be language predominantly affected. It could actually be executive dysfunction that's predominantly affected, so planning, organization, attention. There could be things like tremor and slowness, Parkinsonism. It could be weakness and muscle wasting and paralysis, as in similar to ALS. In fact, there is a group of frontotemporal dementias that travel with ALS and are referred to as FTD ALS. So in panels A, B, and C here, what you see are basically different morphologies, if you will, or different shapes of tau clumping in the brain that depend on what you're looking at. So here, this person most likely had a behavioral dementia. Here, what you have is what we call a tufted astrocyte. This is seen in progressive supranuclear palsy, or PSP, where the major problem is executive dysfunction, a tendency to fall, and Parkinsonism. And here what you see is what we call an astrocytic plaque in what is called corticobasal degeneration, in which one side of the body, the person just progressively loses control. These are different tauopathies or tau-based abnormalities. Now here in panel D, what you have is the findings in the brain of FOS protein, a FOS protein deposit, this thing that looks like a worm. And this FOS protein deposit is seen in a small proportion of people with frontotemporal dementia, typically developing it in their 30s or 40s. It's usually a flagrant, severe presentation when it develops. It is generally not hereditary. And then down here, panels E through G, you have a different kind of protein, TDP43, clumping the brain. And sometimes it's round, as in this panel, and small. Sometimes it's bigger, almost in the same size as a pig body, and sometimes it has a stringy shape. And this depends on what genetic mutation is driving it. And here you have inclusion bodies P62 in the dentate layer of the cerebellum. And this is typical of a particular form of hereditary frontotemporal dementia. And in that form of hereditary dementia, you have TDP43 proteins in the rest of the brain and P62 inclusion bodies in the cerebellum. Now, this isn't, I'm not going into all this to give you a class, but rather to make the point that frontotemporal dementias are actually a family of disease, of brain abnormalities, rather than a single type like in Alzheimer's disease. It's plaques and tangles. In frontotemporal dementia, it's tau, or it's TDP43, or it's FOS. And so it's much more heterogeneous, and it is also associated with different kinds of mutations. Mutations in the tau gene, mutations in the progranulin gene, mutations in what we call the C9orf72, which also accounts for a lot of ALS and FTD ALS. These three genetic mutations together account for over 90%, actually over 95% of all hereditary FTD. But there are other mutations besides. So there's a great deal of complexity to frontotemporal dementia. There's complexity at the level of how it looks when you're in the clinic. There's complexity in terms of the genetic underpinnings, the things that are driving the heredity types. And there's complexity in terms of what you'll see in the brain when you examine the brain. And when we get brain scans, there are also differences in the patterns of atrophy that we see in the brain. And this is useful. We exploit these differences in the patterns of shrinkage in the brain in making a diagnosis in the clinic. So you can see on the right side of this panel an illustration of differences in the atrophy patterns that are being marked in either red or blue, to show where atrophy is likely to be, depending on whether it's behavioral FTD, or what we used to call Pick's disease, whether it's PSP or CBD or something else. So we've illustrated the behavioral dementia. We've talked about how it can be hereditary, how it is. We've talked about the pathological complexity, and we've talked about the hereditary aspects, which are themselves complex. Now, this vignette here is not about FTD. So this is a person who had anxiety about 4 years before I saw him. He was 54 when he came to the clinic. At the time he came to the clinic, he didn't have depression. He had some anxiety. He didn't have paranoia or any psychiatric problems besides the anxiety. His speech was hesitant. He had problems finding words. He tended to stutter and to make sound errors when he was speaking. He had trouble understanding sentences. He could not repeat simple phrases when asked to. For example, no ifs, ands, or buts. He could not do simple arithmetic at all. Even things as simple as 7 plus 8, he couldn't do. Now, he had lost control of his right hand and leg. Partial control. So there was clumsiness on the right side, and there was also jerking. That's what myoclonus refers to, jerking. His mean mental state exam score is 21. Now it turns out that 3 years before I saw him, the earliest signs of the problem were difficulty with spelling, difficulty reading, and problems with calculations, and then these preceded the word finding problems. And when the word finding problems, by the time the word finding problems were established, he also had dyslexia, so he had more severe trouble reading, and dystypia. Basically, he was making typing errors, and he could not understand numerical information. So if I gave you if I said 410-722-2121, you would intuitively know that's a phone number. Now, if I said 218-529212, that sounds like a social security number. If I say 21205, that sounds like a zip code. He had no understanding of this at all. And his right arm, in addition to being poorly controlled, also had a tendency to go up in the air, which is what we call levitation. He had trouble seeing things on the right side, so he had a right visual field defect, and because of this discontrol, he had difficulty dressing himself. A year later, he had declined further. The MMSE score was now 15. He had started talking and moving in his sleep. He had become much more forgetful, and the decline continued until he passed. Now, it turns out he also had a family history of dementia. So he had a paternal grandfather, his mother, and 2 cousins who had had dementia before him. So it turns out when we looked at the brain, this was actually Alzheimer's disease. Notice that the memory problems came when he was already well into the illness, in the 5th year of it. So it turns out that when you're looking at young onset Alzheimer's disease, very frequently it's not about memory. Very frequently it's about language problems, which we refer to as aphasia. It could be executive and behavioral problems, which then make it look like the frontotemporal dementia cases I've described. It could be what I call visual apperceptive. So people will say, I can't see, and they have extreme difficulty appreciating visual information. So if you're in the restaurant and you let them go to the bathroom, they won't find the table. You'd have to walk them right back to the table, or they'll be lost inside the restaurant. They might not be able to find their bedroom if they're in the living room, because space doesn't make any more sense. Visual information, if they're looking for something, it could be in plain view and they can't find it. So that's a form of dementia where people often have visited ophthalmologists and for a year or 2 before they get the diagnosis. Now, it could be apraxic, as I've described here, where the person has trouble with control, with limb control. In this case, the patient I described also had trouble with language. So he had an aphasia and he had an apraxia as the leading edges of the dementia syndrome. So young onset Alzheimer's disease actually has several different ways in which it presents. When it presents as forgetting, it's usually readily recognized, although sometimes a physician will say, well, you're too young, and then that gets in the way of diagnosis. But that's a reflection of physician ignorance or denial rather than it being confusing. But when it presents as a language problem or as a visual problem or as apraxia or executive dysfunction, diagnostic delay can go on for as long as 3, 4, 5 years. Now, it turns out that these differences relate to differences in how the brain is degenerating. And because of that, there's overlap. In terms of the brain degeneration, there's overlap between Alzheimer's disease, frontotemporal dementia, and other conditions. And so then it gets more diagnostically complex. Now, people with young onset Alzheimer's disease, when you compare them to, say, people who have typical onset Alzheimer's disease, that people who are 65 to 80 or the oldest old, what you find is that in the oldest old, it's usually memory primarily and sometimes almost exclusively forgetting. In the typical group, it will be memory dominant, but then you have confusion, disorientation, and other things. And in the young onset Alzheimer's disease patients, as I've mentioned, memory might not be the problem. It could be something else. And it will look that way for a while. As I've also mentioned, it's much more likely to be hereditary. And there are 3 major mutations that cause hereditary Alzheimer's disease. The presenilins 1 and 2, which is what is abbreviated here as PSEN1, but there's PreSen2, and then there's the APP mutation. Now, people with the presenilin-1 mutation tend to develop dementia in their mid-40s. Those with the those with the APP and presenilin-2 mutations will develop it a little later, say at about age 50. So the mutations do make onset earlier, even among people who are young onset Alzheimer's disease. In the young onset people, you're more likely to have these strange sleep disturbances where they're talking or moving during their sleep. I find that they have much higher levels of anxiety and depression. Hallucinations are much more frequent than is observed in the older people. Not that those things don't happen in older people, but they're much more common in the young onset people. There's much more myoclonus, and with the myoclonus, which is shaking, basically limb jerking. And with this limb jerking comes a higher risk of seizures, of convulsions. So we've experienced a number of patients, about 10%, who will have a convulsion at some point. Apraxias, limb discontrol, is more common. Parkinsonism, tremor, shuffling, slowness, also much more common, and much more likely to appear early in the young onset people compared to later. When you do testing, bedside cognitive testing, then the readouts in older people typically is that memory is very impaired. In the younger people, the readout depends on what is happening. So sometimes the readout shows that language dysfunction is severe, or it shows that visual perception is impaired, or it shows that there's striking executive dysfunction. As I mentioned, diagnosis is slower. It comes later. It's more difficult. There's more testing involved. And there's much more distraction from the psychiatric presentation. So I've seen patients who spent 3 years, who complained and then spent the next 3 years being treated for depression or anxiety while the cognitive impairment worsened. So this delay in diagnosis, of course, leads to stress. It leads to a failure to adapt successfully. Now, it turns out that there are no differences in the life expectancy in people who have young onset dementia compared to those who develop it later. So on average, the survival is 8 to 10 years. So that's another myth that is out there. The idea that if you have a young onset dementia, you're more likely to pass more quickly, and that's not true. But there are some special issues that arise. For example, if one is developing dementia in their 40s or 50s, they're likely to be developing it when they're still children to be raised, when there's still a job to work. And the implication is that the household income is threatened. If the household income is threatened, so also is the health insurance. And these things therefore bring a lot of stress. They result in a lot of utilization of informal support care. Now, the brain FDG and MRI PET, I will illustrate to you how these things help us make the diagnosis. So also CSF, amyloid, and tau assays. So it turns out we can now image amyloid, we can image tau, we can measure amyloid, and we can measure tau in the cerebrospinal fluid. The ApoE4 test is not useful. It's useful for indexing people who might be at higher risk in the general population for Alzheimer's disease. It is not useful at all, even for that purpose, in young onset Alzheimer's disease, but it is useful in later life. And when we do the brain examinations, we then find the amyloid and tau distributed in ways that are different from what we find in older people. And that's why the atrophy patterns differ, the brain shrinkage patterns differ, and that is why the clinical symptoms are different. So the natural history then is that depending on, so you can imagine this green line being the first symptom and the red line being the second and the blue line being the third. So in the case of the typical Alzheimer's disease presentation, the one that we're all familiar with, this green line would be memory. It will be the first thing to become abnormal. That abnormality will progress with time. Then you might have disorientation as the red line, and you might have executive dysfunction as the blue line, or maybe those two are reversed. and so on. And so at any point in time at which you see the person, memory is the most severely impaired aspect, and then the others follow. In young-onset Alzheimer's disease, this green line is quite likely to not be about memory dysfunction, as I've pointed out. It could be that a person is having trouble with speech and language. It could be that the person is having problem with visual perception and spatial orientation. It could be executive dysfunction. So when we're doing an interview, it is crucial to know to be clear about the presentation. How did it begin? That's a presentation. What is the chronology? Meaning what followed? It began a certain way, then what happened next? If you get that story straight, and especially get straight how quick this is happening, very often you'll get very close to diagnosis. And then the complications will help to refine that. So what I refer to as complications are things like Parkinsonism, frequent falling, muscle weakness and paralysis. So if you have muscle weakness and paralysis in a person whose story begins with executive dysfunction and misbehavior, you're probably and it's progressing rapidly, you are talking about FTD ALS, most likely. If it begins with language dysfunction, is moving slowly, and then there's executive dysfunction and memory is fine, orientation is fine, most likely you're dealing with a language-based FTD. If the person is acting like a child, is being unruly and annoying, and has good memory, good orientation, it's likely to be behavioral frontotemporal dementia, unless it's a psychiatric problem. So the interview is crucial. It is the mainstay of the clinical evaluation. It is what will put you in the ballpark for making an accurate diagnosis. Now, these complications are also important to catalog, because that's what's also going to inform care. It's not enough when someone walks through the door just to make a diagnosis. You have to then articulate care, and that means you also have to know what this problem that has developed in a certain way, evolved in a certain way, at a certain tempo, is doing to this person and to the people around them. The mental state and the cognitive examination, we do those. So we have these instruments, the MMSE, the MoCA. Those are meant to benchmark where things stand now, but they're not very helpful for diagnosis, as I've already illustrated. People with FTD, for example, can have a near perfect score even 4 or 5 years into the illness. So making a diagnosis on the basis of a score is a poor thing to do. You have to have the story. How did it begin? How is it evolving? How quickly is that happening? What else is going on? So the neurological examination is helpful for describing these complications. And as I said, these bedside scales will allow us to benchmark things. So if you get that story right, then what you're going to have is something that began primarily as a memory problem, an amnesic problem, and your considerations will be Alzheimer's disease. If it's moving very quickly, maybe an autoimmune dementia. If it's non-amnesic and it's aphasic, then it's either Alzheimer's disease or some language form of FTD. If it's visual perceptual, it could be Alzheimer's disease, it could be dementia with Lewy bodies, it could be progressive supranuclear palsy in rare cases. If it's moving very fast, maybe CJD, and so on. So you can see the logic in this graphic. And when I say it this way, then it almost sounds like, well, then the diagnosis should be easy to make. But only if one understands this, and only if one painstakingly collects the information. Now, when we do the neuropsychological testing, even in people so you take people with memory problems, where the problem is primarily memory, but young-onset Alzheimer's disease versus late-onset Alzheimer's disease, even when a problem is mainly mainly memory, the young-onset people are more likely to have visual spatial problems. They're more likely to have executive dysfunction. They're more likely to have attention problems and language problems than their counterparts who are older, even when the phenotype is predominantly about memory. So there are differences in neuropsychological performance. Now, I've talked about brain imaging quite a bit. The MRI is basically, let's say you had to we want to look at the brain. We want to know what the brain looks like. Where is is it shrinking in a particular way? I've already explained why that's important to know. Depending on the phenotype, depending on the kind of dementia, the shrinkage will be in one region or another. But we can't crack open the skull, so we go past the skull, and that's what the MRI does for us. You can do that and look left to right, as in the top panel on your left. You can do that and look head to toe, so up, down, from the jaw up to the top of the head and back down. That's the panel, the middle panel on the top row. And you can also go front to back. And different structures are better illustrated by either going side to side, up, down, front, back, which is the front back is the last panel, is the rightmost panel on the top row. So here, the top left panel, what you can see is similar to what I showed you when I showed you the brain of someone or the brain of a pick disease case. The frontal lobe, you can see that there's much more space in the frontal part of the brain, the part of the brain that's close to where the nose is and the forehead, compared to the back, where you can see that the gyri are thicker and the spaces are thinner. Now, in the middle right panel, what you see is bilateral shriveling of both temporal lobes. The frontal part, the anterior parts, or the frontmost part of the temporal lobes. These two panels show cases of frontotemporal. Actually, all of these panels here show cases of frontotemporal dementia with different distributions of the atrophy patterns. In the top left, that's a behavioral. The other two illustrate language dysfunctions. Now, sometimes the MRI scan is normal, in which case we do an Ftg Pet scan, which basically means we give the person fake glucose, which is the energy currency of the brain. We tag that fake glucose, which cannot be digested, which buys us time to see where it goes. We tag it with a radioactive signal so that we see where exactly it goes. It gets injected. A little time is allowed. The person has been instructed not to eat the night before so that there isn't the real glucose to compete. And then we look at the distribution patterns, and in panel, the panel on your left at the bottom, what you see is low uptake in both temporal lobes. In the middle panel, the uptake is low in the left frontal area, and all the way to the bottom right, you can see that the signal is bright at the back of the brain, but not in front. And so here's a person where the MRI was normal, the phenotype was behavioral. The Fdg Pet scan shows us that tracer uptake is reduced in the frontal lobes or in the temporal lobes in the case of the leftmost panel, bottom left panel. And that allows us to buttress the diagnosis that we already made clinically. There are gradations of atrophy, of course, which correspond to severity. So atrophy progresses over time, and there are scales that grade this atrophy so that we can use that information in clinical trials, for example. So you can see here grade 0 to 1 to 2 to 3 to 4. In this case, in the top row, it's for the frontal lobes. In the lower row, the focus is on the anterior temporal lobe. So if you look at the lower half of that figure, you can see that the tissue is disappearing at the bottom of the figure. And that's the temporal lobe is shriveling. And the same thing is illustrated in the lower panel. This is a visual rating scale that was developed for frontotemporal dementia, but there are similar visual rating scales for Alzheimer's disease. Now, here is the same illustration, MRI and Fdg Pet for Alzheimer's disease. So this was the patient I mentioned earlier, the 54-year-old gentleman who had speech and limb control problems. And what we saw here is that if you look on the panel on your left, there's more tissue on the part of the panel that is to your left. That's the right side of his brain, because imagine that you're standing at his feet looking up. His right will be on your left. So the left side of his brain is smaller in general, and then the lower half is smaller than the upper half. So he has focal atrophy that is predominantly posterior and a little bit more worse on the left. And the FDG PET scan, you can see that the uptake of tracer in the parietal areas, which are basically the lower half, is much lower. If you look at the sides on the lower half, you can see the dark signal is it's darker at the top, which is closer to normal, and clearly abnormal in the lower portion, which sort of corresponds to the MRI. So this is a picture that is typical of Alzheimer's disease. So in frontotemporal dementia, you have either atrophy or loss of signal in the front parts of the brain. In Alzheimer's disease, it's in the back parts of the brain. So you can see how a patient who had language problems and had some motor problems, so it suggested maybe Alzheimer's disease, but it was ambiguous. People might reasonably have said it could be FTD. But then you get the FDG PET scan. You get the MRI and get the FDG PET scan, and then you're more confident in calling this a case of Alzheimer's disease. Now, in the last 10 to 15 years, we've developed the ability to measure amyloid and tau in the brain. So now we can get more direct. Because atrophy patterns and FDG uptake patterns are essentially lead us to inferences that are high probability inferences, meaning that it's much more likely if you have a particular story and then you have a particular finding on the MRI or the PET scan that it'll be Alzheimer's disease, or it'll be frontotemporal dementia, or it'll be vascular dementia or something else. Now we can actually tag amyloid in the brain and say, regardless of the story, regardless of the MRI pattern, amyloid of a certain amount in the brain means this person has Alzheimer's disease, even though it mimicked frontotemporal dementia. So you can see that the potential for higher accuracy exists. The potential for resolving ambiguous cases that are ambiguous either because of how things have evolved or because the patient and the family are not able to give a story that is complete. So here you have NC here refers to normal controls. And as you can see, there is little color in the brain panels there. And then you look at Alzheimer's disease. So this is a PIB, refers to Pittsburgh compound B, which stains amyloid, which attaches to amyloid. And you can see in the case of Alzheimer's disease or language variant, logopenic variant PPA, which is basically language-based Alzheimer's disease, you can see that there's a lot of staining with amyloid. Okay. And the distribution of this amyloid seems to be similar, but not completely so, with the typical amnesic Alzheimer's disease versus the language-based version. Now, in contrast, you have people with behavioral FTD or with semantic language problems, which is frontotemporal dementia, and you can see that there's very little Pittsburgh compound uptake. And this is compared to the FDG PET scans just to illustrate where the abnormalities would be. So you have an energy scan compared to an amyloid scan. And what you can see is that the energy scan basically shows you that there are abnormalities, even in the frontotemporal dementia cases and as well as in the Alzheimer's disease cases. But the Pittsburgh, the amyloid scan only shows you the abnormalities in those with Alzheimer's disease. So you can see very quickly that an amyloid scan can make it possible in the clinic to separate Alzheimer's disease from frontotemporal dementia with a very high level of confidence. During the pandemic, in May last year, the tau PET scan the first tau PET scan was approved. So now we not only can tag amyloid, we can also tag tau. It turns out, and this panel sort of illustrates that, it turns out that the tau that has been, the tau ligand that we use now to tag amyloid in people with Alzheimer's disease is not very effective in tagging the tau that is caused by frontotemporal dementia. But it is, in this panel, clear that regardless of whether the Alzheimer's disease is visual spatially predominant, whether the abnormalities are visual spatial, That's what is referred to as posterior cortical atrophy here. Or language-based, which is the panel B, logopenic variant. Or amnesic, which is the forgetting, memory-based. So regardless of what the phenotype or the clinical presentation of Alzheimer's disease is, a tau PET scan will label the abnormalities. The current tau PET scans that will label the abnormalities accurately if it is Alzheimer's disease. So these panels all illustrate the different forms of Alzheimer's disease and show that tau PET's ligands will label the tau in these patients. Now, we've talked a bit about hereditary, about the likelihood of hereditary, the higher likelihood of hereditary dementia in people with young-onset dementias. Sometimes we have a family history, such as in that vignette I showed you, the person who, his grandfather, his mother, and 2 other relatives. So you have a 3-generation pedigree of dementia. You have his grandparent, a grandparent, and you have a parent and the parent's siblings, and then you have the person. Now, when you have a 3 straight line generation, no skipping, that's an autosomal pedigree. That's what we call a 3-generation pedigree, and that is the typical standard for ordering genetic testing. So if you have a family history, say of a cousin who had dementia, but none of your parents had dementia, then you are not at risk for hereditary Alzheimer's disease or hereditary frontotemporal dementia, and etc. Not unless you are adopted without being told, which doesn't happen much these days, or there was some mischief that has been swept under the carpet. But if one is truly the biological child of a parent who lived to a long life and did not have dementia, child of 2 biological parents who lived long lives and did not have dementia, then there is not dementia in that person is not going to be hereditary. So we don't order genetic tests merely because there's a family history. Order them because there's a 3-generation pedigree, or there's something close to a 3-generation pedigree. What do I mean by that? Say, for example, you heard that that person at the top of this family tree, the red box, you heard that person was in an asylum and lived his life in an asylum, that there was some psychiatric thing, and that was happening in, say, 1901. You can't get the records. We might count that because it is close, even though we don't know the details. It turns out that up until the 1950s, it was not uncommon for people with young-onset dementias to end up in psychiatric asylums, because then they were mistaken for people with schizophrenia or bipolar disorder, and then they ended up in an asylum, and then they passed away in the asylum. And back then, people went into the asylum and did not necessarily come home, because these asylums were like large communities, and they existed until JFK came with his deinstitutionalization policy. So the point being that sometimes what we have is a 2-generation pedigree rather than a 3-generation pedigree, with either absence of information for the topmost generation or ambiguous information, and we will often treat that as a quasi 3-generation pedigree, particularly if there are multiple family members in the next generation up. So I will pause here. It's been a lot of information load. So I'd like to know if there are any questions at this point.
There are many questions coming in, Dr. Onyike, so I will share just a few of them with you, and then we can move on.
Yes.
A couple of questions have come in regarding trauma. Can childhood trauma, physical or emotional abuse, be a factor in a person having dementia? And also, was there a history of trauma in any of the early onset patients that you shared about earlier in your presentation?
So the patients I shared in my presentation, there were no, with the exception of the third one who had a 20-year history of anxiety. The others did not have any prior psychiatric history. None of them had any history of personal trauma. As far as we can tell, so people have explored the role of long-time stress and personal trauma as a risk factor for Alzheimer's disease, and the evidence is weak. In young-onset dementias, there's no, as far as I know, there is no evidence that emotional trauma, because I think that's what we're talking about here, or psychological trauma will predispose a person to a young-onset dementia. Now, physical trauma is a different story. We've heard about post-concussive syndrome, repeated concussions. That's been highlighted in the media, and rightly so. And even single severe head traumas can lower the threshold for developing dementia or produce the dementia itself. So that's different. But psychological trauma, I don't think the evidence is strong.
Okay, thank you. We have 3 questions related to diagnosis, so I'm going to try to sort of put them together. The first is, before visiting a neurologist and obtaining proper testing for dementia, what behaviors should lead family members to seek testing? Also, there's a question about if a person has been diagnosed with myoclonic behaviors, when should they seek neurologic testing? And lastly, do you recommend brain scans regardless of the age of the patient to assist in diagnosis?
Okay, I missed part of the first question. Could you repeat it?
Sure. The first question was basically, what behaviors would you look for to determine that that testing should be pursued?
Okay, thank you. So if a person's behavior has changed, so if they're engaged in uncharacteristic behavior, particularly behavior that has social import, so even people with depression, for example, might be withdrawn. They might not want to interact with people, but they are not likely to act like children, so to speak, or act in ways that are socially bizarre. So they're not likely, for example, to walk away when someone is talking to them, unless there's been an insult or something like that. There will be an explanation. Now, if a person has compulsions, they're repeating stuff and it's new. Now, if it's someone with OCD or someone who's just obsessive, what we like to call obsessive compulsive tendencies, that would have been there all along. It's not going to be new. With OCD, the OCD typically begins when people are in their teens, so that history will be there. Even the people who have tendencies but don't have a disorder will know they have this, and the people who know them, family, will know that it won't be new. So if it's new, and particularly if the compulsions are traveling without obsessions, so the person seems to be unaware of their compulsions, that's a red flag. If you see that a person has become clumsy, that is a red flag. If they're apathetic, uncaring, indifferent to what's happening to them, that is a red flag. Because typically people with psychiatric problems know. They might be defensive, they might argue with you, but they won't be completely indifferent. So those are the kinds of things I would call red flags, and those are the sorts of things to report. Now, when you get to an evaluation, I think it's imperative to have a brain scan. There's no escaping it, because that's how you demonstrate that this problem arises from brain change, a structural or physiological change in the brain. If the brain scan, if the MRI is normal and an Ftg Pet is normal, then it's most likely not a dementia. It may be a bizarre psychiatric problem, but it will not. You cannot have a neurodegenerative disease and have a normal brain PET scan. You might have a normal MRI if it's early, but you will not have a normal PET scan. So the brain imaging is crucial. And I think I may not have answered the middle question.
The middle question was about if a person has been diagnosed with myoclonic behaviors, when should they seek a neurologic testing for dementia?
So you mean like myoclonic? So I assume that what is being referred to as myoclonic behavior is jerking, is repeated jerking. Now, generally you should get a neurological evaluation for that. But if the myoclonic jerking is happening in the absence of cognitive decline and behavioral change, then it's very likely that it's not a neurodegenerative dementia. It could be a myoclonic epilepsy, for example. So I would say, regardless, one should get a neurological evaluation if it's new. If it's been lifelong and it's no worse, then maybe there's an explanation. Or occasionally people might have jerks once in a while, maybe when they have had coffee or something, too much coffee. If that's a long-standing story with no change, then maybe that's different. But if it's new, it could get a neurological examination. But what I will say is that it's unlikely, in the absence of cognitive decline or behavioral decline, it is unlikely to be due to dementia.
Thank you. We have a couple of questions about genetics. Are there other genetic mutations where there might not be enough evidence for a definitive connection to FTD ALS that are currently being considered for research, such as the sequestrum 1 mutation?
That is a brilliant question, and the answer is yes. We have had patients, for example, with a very clear FTD ALS syndrome, even autopsy confirmed, with some family history and they're negative for the C9 mutation, which would be the prime suspect. They're negative for the progranulin mutation, which would be considered unlikely, and we would not expect them to have a tau mutation in that scenario. There are other mutations that have been described that I didn't highlight. The TBK1 or tank binding kinase, the DNA, the TDP43 mutations. Collectively, these probably account for less than 2% of all hereditary FTD, and very likely we haven't discovered them all. We've discovered the ones that are the big players. We believe we've discovered the major players. So.
And are genetic testing covered by Medicare or other insurances?
Yes, with proper documentation. Yes. Now, co-pays, of course, will vary according to insurance, but it's often possible, especially if you're seeking care in a research center, it's often possible to get the testing without cost.
Okay, wonderful.
And that is much more likely to happen if you're doing it with the help of a genetic counselor.
All right, thank you. There are a variety of additional questions, but I want to give you a chance to proceed with your presentation, and we can address these at the end if that's okay.
Yes, absolutely. That will be fine. So, a person, I mentioned in the beginning that it's imperative not merely to make a diagnosis, but to really understand why a person has come. And that's because, at least the way I conceptualize care, you want to know what the problem is, but you want to know why they have come to you at that time, because coming to you at that time might not be about a diagnosis. It might be about a crisis. Person, for example, has been told by their supervisor at work that things are not going well. You have to get an evaluation. If you don't, we're going to fire you. So that's a crisis. So giving them a diagnosis does not necessarily solve the crisis, but it helps. So there are the other steps to take, which involve intervening by articulating the disability, articulating how the disability relates to the condition you're proposing, and what objective data you've used to make those conclusions. I've found that very often people have delays in getting disability because the physician is so caught up in having an accurate diagnosis and not being sure about the diagnosis. Well, if you're sure about the disability and you're sure it's dementia, you can write what is required for a person to approach their employer and approach their disability benefits, because that's a clerical conversation, not a clinical one. And so that's something that we're often able to correct very quickly, even if we are still saying it's AD, FTD. We think it's more likely to be AD, but we're not sure. I will write Alzheimer's disease now, recognizing I might change it later, in order for this person to get the things that they require to be able to adapt. Now, sometimes the issue is agitation, anxiety, hallucinations that are very distressing to the person, to the family. The person can't sleep. That's another problem. In this situation, your role is to make a prescription, prescribe relief. Often it could be a strategy, it could be a medication. Frequently it's a medication. But you're relieving distress. And of course, when you tell someone they may have a dementia, you're telling them something that no one really wants to hear. And you're attaching to it prospects that are not attractive. This is how it's likely to play out. There is no cure, and so on. It's easy to say, but it's not easy to hear. And so people it's stressful, it's demoralizing, and so you have to be there to provide guidance, to provide support, to provide guidance, to provide clarifications. Is this going to happen to my children too? Is a big question I get, and you have to be ready to answer that question. You have to be ready to answer that question, and sometimes that question requires us to proceed with genetic testing, not of those relatives, but of the person who is in our care, because if they don't have a mutation, then the rest of the family can exhale, at least in relation to that particular question. So it's important to be present, both at that evaluation and subsequently, in order to provide these kinds of guidance, to provide the support that people will need, to provide clarification, provide direction. What does the future hold is a frequent question. Okay, we're in the clinic. You've heard what we have to say. You've told us the MMSE score. What should we brace ourselves for in the next 6 to 12 months? That's a frequent question. And we don't have a crystal ball, but I think we can often make educated guesses, particularly for somebody who is a repeat, who is coming for a follow-up visit as opposed to a brand new visit, first-time visit. So that's the role. Make a diagnosis. But sometimes people have come to me when their diagnosis is already settled. They've come because they require guidance, and they're people that they've been working with say, look, this is beyond us. We've been able to make the diagnosis, but we want you to be in the care of an expert. Or we are solving problems, or we're providing relief. So care has to be multifaceted, individualized. That's what this whole thing implies. Right now, we are working to have curative interventions. That includes prevention. But in the meantime, we can do a lot to ameliorate the symptoms with neuromodulation. Some of that is medication. Some of that is devices. Brain stimulation, for example, is coming on. Some of that is psychotherapeutic. And this overlaps with rehabilitative interventions. And palliative care, which I'd like to distinguish from hospice or from end-of-life care. Palliative care is not necessarily end-of-life care. So palliative care really is about comfort and preferences, but it does encompass hospice care. So there are a variety of psychosocial interventions to do these things. Some of these are psychotherapeutic methods to provide activity, to provide structure, to provide respite, essentially, for the individual, for family, and to provide social engagement. And then, of course, there are more explicit care support programs to help carers feel more confident or actually acquire skills that will help, particularly when things may get difficult. And in the last 10 years, there's been a development in the area of rehabilitative devices and programs. Some of these are smartphone and tablet apps. Some of these are alarms and trackers. Some of these are even like Fitbit type devices to make it easier to provide care for a person and to maximize the possibility of a person being cared for at home as opposed to in a residential home. There's a program here that's developed here, Maximizing Independence in the Home, Mind at Home, developed at Hopkins, where rather than a person moving to residential care, that kind of expertise is brought to them in their home. And this has been shown to be quite effective in reducing stress for the individual, for the carers, as well as delaying, maximizing their time at home. When we prescribe medicines, what I refer to as neuromodulators will be things like donepezil or Aricept, memantine, which is Namenda, rivastigmine, which is Exelon, and arazidine, which is galantamine. These are medicines that we are prescribing, along with amantadine, with the explicit goal of improving cognition or slowing the rate of progression of cognitive symptoms. Now, these medications do not slow the rate of brain degeneration. What they're doing essentially is ameliorating the impact of that degeneration on everyday life by reducing or mitigating the manifestation of symptoms. Beyond that, we're doing things to relieve distress, whether that distress is coming from anxiety, irritability, disruptive compulsions or impulsions, paranoia, hallucinations, sleep dysfunction, and so on. And this comes from the standard psychiatry playbook. with a few modifications. Firstly, there's a bit more creativity, and we try to start with lower doses. What do I mean by creativity? For example, we might prescribe bupropion, which would ordinarily be thought of, which is marketed as Wellbutrin most commonly, might be thought of as an antidepressant, but can be used in cases where apathy is the problem. When we use stimulants, it's the same thing. We're dealing with inattention and distractibility, but also often we're dealing with apathy. So that's not necessarily part of the standard psychiatric playbook when we focus on apathy that way. Another area where there's creativity is with hyperphagia, overeating. And the only medication that I have found, and other colleagues who've looked at this, have found that can help with overeating is topiramate. And most other things will not help. Now, wandering is one behavior for which pharmacological intervention pharmacological intervention is just generally not helpful. Not unless you're going to drug the person, tranquilize them to the point of sleepiness or stupor. Wandering, in my experience, can only be managed through some combination of behavioral and environmental strategies. So there is a working model for disease evolution that is informing research today. This is true for Alzheimer's disease, it's true for frontotemporal dementia. I suspect it's true for most of the neurodegenerative dementias. And the idea basically is that clinical status here basically refers to the presence or absence of symptoms. So people are normal at some point for a long time in their lives. And there is a point at which they start to cross the line, they start to develop symptoms, and then there's another line to be crossed where it's clear they have dementia. But there are events that begin that are well in advance of that, 10, 20, 30, 40 years now, it's been documented, in which atrophy begins, but at this point, at the early point, the atrophy can be measured if you're doing repeated, say, annual images. But it will not be the sort of atrophy that is noticeable if you put that person's brain up next to, say, their neighbors. You won't see it. So it's not something you can see with the eyes. Not until the person has gotten into the symptomatic phase. And along with that, there are inflammatory events that are happening. There are other molecular events that are happening, which we want to capture. And the reason we want to capture these events and define them properly is because the holy grail is to intercept neurodegeneration before you cross the first line, which is the transition from being asymptomatic to being symptomatic. Ideally, the earlier we can do that, the better. If we're going to stop neurodegeneration, we have to keep in mind that cure has two meanings. The first meaning is that we stop the degenerative process, it's done. But that doesn't mean that the person gets back what they've lost. So that's the second meaning, to restore lost function. So you can imagine if a person has diabetic gangrene and you amputate, you have cured the gangrene, but you've not cured their function. For that you need a prosthetic limb. So there's a similar concept in play here. And so the earlier we can intervene, the much better the likelihood that curing neurodegeneration will translate to functional cure. So that's the concept. Now, you imagine that you have a medication that you think can do this, and you give it to someone who's asymptomatic. You're not going to be able to rely on clinical symptoms because they haven't developed. So the only way to define effectiveness would be on the basis of molecular events and changes in MRI in brain atrophy. Now, the brain atrophy change is too slow for clinical trials, so we really need to tap into these molecular events, and that's what a lot of the research today is trying to do. There's a consortium. This is the United States consortium, all FTD, for frontotemporal dementia. You can see that it's distributed around the country. And the Young-Onset Alzheimer's disease consortium is also similarly distributed around the country. You can see me hiding in the back there on the left. So the distribution, the centers involved overlap. There's a very broad overlap. I think virtually all the centers you'll see here are also involved in the Leeds consortium. There are a few notable ones that are not on this map. I want to highlight in particular the University of Indiana. Indiana University. And the reason I highlight that is because the Liana Apostolova, who is here in blue with the purple lapel, sitting next to Maria, who leads the Alzheimer's Association, is the lead investigator for the early onset Alzheimer's disease research consortium. So that's based in Indiana. And then you have a similar consortium in Europe focused on frontotemporal dementia. You have similar consortiums around the globe focused on frontotemporal dementia, focused on young onset Alzheimer's disease. There are consortia forming for dementia with Lewy bodies and other conditions. And the objectives, as I've mentioned, are to begin to define the preclinical states of frontotemporal dementia, for example. The lines you see on this graph show which regions of the brain decline steeply as a function of having a hereditary mutation well in advance of crossing the line 0, the vertical line 0, which essentially is the line at which symptoms begin. So there are regions of the brain that are showing steep atrophy patterns, not necessarily striking, as I said, if you were to look at the MRIs cross-sectionally, but when you plot MRI to MRI, you can see that atrophy can be detected as early as 20 years before people develop any symptoms. So we're beginning to catalog that, and we're beginning to catalog the earliest symptoms. Again, at this time, it has to be done in people with hereditary, with mutations who are asymptomatic, and then you follow them over time. And the reason it has to be done that way is because that's how you know if a person is, if you go out in the public and look in the community, the only way to know who is at risk for developing frontotemporal dementia is to follow people who have mutations. So that's what we do. The people are beginning to look at what behavioral symptoms might reflect this as well. So it's not just looking at cognition, memory, orientation, and all that. It's also looking at other symptoms that are behavioral in order to articulate not just MCI, which you're already familiar with, mild cognitive impairment, but also things like mild behavioral syndromes and mild motor syndromes that might evolve into dementia in time. We're beginning to define molecular markers. So this is data looking at neurofilament. It turns out that neurofilament levels change around the time people are beginning to develop symptoms in all forms of frontotemporal dementia, in Alzheimer, and all forms of Alzheimer's disease as well, in other forms of neurodegenerative disease. So it's non-specific, but it is specific in the sense that the levels rise at the time at which a person who is a mutation carrier is going to begin to develop symptoms. Now, if this is also true there's now some data showing that this is also true for people who don't have hereditary mutations, that the takeoff point is defined by neurofilament. So what we now have is something that what we're beginning to do is develop a panel of biomarkers that might allow us to screen in the population of people who do not have hereditary mutations, who do not have a family history. And that's huge, because then we can start to identify people who are sporadic cases in advance of their developing symptoms, which is crucial because the majority are not mutation carriers. Now, plasma tau and tau 2017 and 2181 are very sensitive for Alzheimer's disease, and this panel will show you here that plasma tau is elevated in Alzheimer's disease. So this is panel A. You can see the boxes that are high off the ground, and you can see that again in panel B. And these three boxes that are off the ground are different forms of Alzheimer's disease. So one is amnesic, the other is language, the other is visual perceptual. And what it shows basically is that by drawing a blood sample and measuring tau 2017 or tau 181, you could actually diagnose Alzheimer's disease. So blood tests for Alzheimer's disease are on the horizon, is the point of this panel. And this other panel here shows the same thing. Essentially, that plasma tau 2017 and plasma tau 181 have a strong correlation with amyloid status. So the red boxes are all the people who are amyloid negative, and the green dots and boxes are the people who are amyloid positive. And what you can see is that plasma tau 2017 and 2018 are both close to 0 in people who do not have Alzheimer's disease as measured by amyloid PET, and are otherwise high in others. So again, making the same point that the blood test is around the corner. The other thing that is a major area of development is beginning to understand how symptoms are expressed. Why is it that some people have language problems while others have memory problems? It turns out that this has to do with how atrophy is distributed through the brain, and it's an issue of networks. So you have regions in the brain that may be spatially separated. So you might have one area and another area in the brain, but they fire together. And we can capture that synchronous firing, which means that they worked cooperatively. And what we found is that these connectivity networks, which is how we've defined them, degenerate together. And so the distribution of atrophy reflects connectivity networks in the various syndromes. And we began, this has opened the door to looking at the basis for differences, for selective neuronal degeneration. So there are a lot of interesting things happening today. All of this ultimately is geared towards developing drugs. That's why we're doing this, to develop drugs that will decisively turn the tide. So there's a whole raft of mechanisms. I won't go over them one after the other because it won't make it any more intelligible. But basically, it ranges from looking at amyloid and tau processing abnormalities, to looking at cell repair, to looking at why proteins clump, to looking at the sewage system of the brain, whether things are effectively cleared from the brain, to looking at the energy systems. So that's why people are looking at mitochondrial dysfunction. They're looking at the inflammatory mechanisms to see to what extent brain inflammation is a factor. And we're also looking at gene regulation, even in people who are sporadic cases. Is gene dysregulation causing essentially premature aging in the brain, in regions of the brain? So there are so many good leads, a lot of progress, and I think there is cause for optimism, although of course it can't happen. It can't happen fast enough. So the life course is a complex phenomenon, as we all know, and there are various, it intersects with various personal, social, communal factors. But there is value for, even in a neurobiologic sense, there's value to taking this kind of age-related perspective and looking at dementia care and looking at dementia research, because firstly, different life stages present different kinds of challenges. As I mentioned earlier, it can matter at what stage in life. It can matter for a family unit at what stage in life dementia comes. So when a parent is in their 40s or 50s, perhaps they're teenagers in the home, in their formative years, and disruption at that stage of life can leave a lasting mark. It can also derail education for the children. It can create hardships for the family in terms of acute drops in income. It can cause, fortunately, through strong advocacy from the Alzheimer's Association, from the Association for Frontotemporal Degeneration, and others, it is possible for people to fast track with a diagnosis in hand. It's possible for people to fast track to a disability status, which is a huge help, and also to fast track to Medicare. Again, a huge help for mitigating the problem of loss of income and loss of health insurance. This age-related model has highlighted differences in phenotypes and allowed us to hone in on those differences in phenotypes and ask, what do they mean for brain degeneration? What do they mean for brain function? What do they mean for the mechanisms by which neurodegeneration begins and the mechanisms by which it spreads through the brain? It has now allowed us to hone in on the place of genetic mutations in driving at least some forms of dementia. And these genetic mutations are vital, because by exploring how a mutation derails an aspect of brain physiology, we can zero in on mechanisms, and we can identify steps in the process for which we can design drugs to intervene. So there's a lot of value, in my opinion, and in the opinion of others, to looking at dementia from this perspective. We are involved in the enterprise of trying to understand these conditions better and develop treatments from that understanding. And so this slide is a listing of all of these of the efforts that I'm directly involved in, and in most cases leading. And you can see the key contacts. The topmost line is about our clinic. Myra Franklin, who's our coordinator, who's our front desk person, is phenomenal. That's what I hear all the time. And we have terrific staff, and we're working also with a lot of terrific people within the institution and around the country. So this is where I'll stop, and I suppose I have enough time to take the remaining questions. I hope I do. Thank you very much again for the invitation.
Thank you so much. Thank you, Dr. Onyike. We do have about 10 minutes for questions. And I'm going to start with one that's asking about interventions. Are there forms of non-medical interventions, for example, arts, crafts, music, brain games, that would work better with different forms of dementia? So for example, with FTD, would music be more effective than brain games?
I don't think it's, well, first of all, there are a variety of interventions. As you know, these are not easy things to scale because people differ in what resonates, on a personal level. A lot of these interventions are exploiting personal biographies, if you will. So for example, playing classical, when you play music, you still have a choice to make. Is classical music better than hip hop? Well, it depends on who. Even though in general you might say that classical music is likely to be more soothing. So there's a lot of it that has to do with preferences. Should you burn a sweet-smelling candle? Things like that. And that goes back to the era of reminiscence therapy and aromatherapy and things like that. It's an area where there's a lot of room for creativity. It's crucial to have a biography of the person, as I mentioned. Years ago, I had a patient who would wake up in the middle of the night and he was going to work. And nothing could dissuade him that it was the wrong time of day or that he was no longer working. But he had a particular quirk, which was that he would never, ever step outside without shoes. And so his wife just hid the shoes. And so he'd wake up, get ready to go, and can't find shoes. And he'll say he's going to work. You say, bye, honey. And he'll go nowhere. And then eventually he'll come out and get back in bed. And that problem eventually cleared. So one can leverage quirks that way. You can also leverage the symptoms. You can exploit the symptoms. We had a patient who insisted that he had to check the suspension of the cars. And as you know, cars in this era are cranky. If you're not the owner and you get too close and move the car about, then the car complains, the alarm goes off, and the neighbors are irritated after a while. Initially they're understanding, but after a while it's old. And so it's a compulsion. And so we sit with him and we say, look, this is an old-fashioned way of doing things. These days you use a checklist. And the checklist is based on visual inspection. So he's still doing the compulsion, but now the compulsion is about checking off boxes on a sheet of paper. It's no longer rocking the car. So you'd redirect the compulsion. Now, there are other kinds of programs that have to do with carer skills, as I mentioned earlier. Carer skills, problem-solving therapy is the best described for frontotemporal dementia. It's also very useful for Alzheimer's disease, but teaching caregivers to frame the problem as a sort of interaction that can be reshaped. So anyway, the short answer is yes. There's plenty of room for behavioral intervention. Some of it is empirically demonstrated. Some of it is going to be anecdotal because it's very much biography based and cannot easily be transferred from person to person. But yeah.
Thank you. I have someone asking, do you recommend Prevagen? I'm tempted to take it, but many people say there's no scientific proof that it works.
Yeah, I think it's expensive. Chalk? It's not helpful at all. And even the premise that you read on the website is, in my opinion, nonsense. From a scientific perspective. I've had a number of people who've taken Prevagen. We've had the conversation where I tell them I think this is nonsense, but they would really like to try it, and we agree. There are no adverse effects that I would consider. The main adverse effect is that it's expensive. Okay, so you don't get bang for buck, in my opinion. If you're asking my opinion, it's no, don't take it. I haven't seen, even the people who in my care who've gone ahead and taken it have mostly discontinued it because there was no benefit and it's expensive.
Okay. Can younger onset Alzheimer's patients stay on donepezil or memantine for many years? I've been told effectiveness, if effective, is for a couple of years. When do you know it's time for in-home care, or when residential care is preferred or recommended over home care?
Okay, so there are two questions in there. I wouldn't necessarily link residential care to the medicines, because my experience, there are two ways to think. There are a number of ways. One is the medicines may help at the time they're started, help symptoms improve. They may help to shore up current function. So even when the person is declining, you stop the medication and they drop, and then you start it again and they're better. It won't stop the degeneration process, and it wouldn't stop the decline, but it might mitigate it. And we don't really have a firm knowledge of how long exactly that lasts. The other aspect to this is that sometimes behavioral disturbances are quieted, even if we're not sure about cognitive dysfunction. The most best-known example of this is in dementia with Lewy bodies. Hallucinations can be quieted by just prescribing donepezil or one of its relatives. And the same is true for some of this visual. My experience with the visual perceptual versions of Alzheimer's disease, particularly when they come with hallucinations such, is that prescribing a cholinesterase inhibitor can really settle any, can reduce anxiety, it can settle hallucinations in some cases, and it often results in a significantly improved function, even as quickly as a month after it's been prescribed. Particularly the rivastigmine patch, because it's more potent. So that's typically what I prefer for young onset Alzheimer's disease, the rivastigmine patch. The tablets are harsh on the tummy. Many people will not be able to tolerate the maximum titration. The key obstacle is that many insurance pharmacy providers will not pay for the rivastigmine patch unless you've already tried you've tried the tablets, or you've tried donepezil, oral donepezil, and maybe there's been like indigestion or some reason why the person can't take it, or the argument is that it hasn't been effective. But for those for whom insurance is not an obstacle, that's what I prescribe first.
Is there a difference between MCI with memory loss and dementia? And are there levels within MCI?
The difference is that MCI is not dementia. So people have cognitive complaints, but they're able to go about their normal lives for the most part. Whereas with dementia, so when we say a person is normal, then they have MCI, then they have dementia. Okay, so MCI means I have some symptoms, but I'm fine. Dementia means I have these symptoms and it's interfering with my life. So the difference between the dividing line between MCI and dementia is really about function. But a person can have Alzheimer's disease, at least you can have amyloid and tau accumulating in the brain, and up to a point you're still normal. No one knows about this, and you wouldn't know unless you had a scan for some reason, and you'd only have a scan if you were in a research study. But at some point you'll have MCI, and it could be MCI with memory, it could be MCI with language, it could be MCI with behavior or executive dysfunction. And at that point, we would say, okay, the person is beginning to cross the line to dementia. Now, are there levels to it? We haven't defined explicitly levels, but it definitely can vary in severity. And so sometimes you see a person with MCI and you're not sure if they're anxious because maybe a relative recently passed from it or recently was diagnosed. And then in other cases, it's very clear there's a problem. It's just, is it time to call dementia or not? But we haven't defined explicit grades. We probably should.
And Dr. Onyike, what is your opinion about taking Aduhelm via monthly infusions?
So I was on the FDA committee that heard the application and voted 10-0 against. There was one abstention, but that wasn't me. I think that firstly that the approval was wrong, in the sense that the aducanumab, which is the name, Aduhelm is the trade name, clearly clears amyloid from the brain. For that, there's no question. It's not just that it clears the amyloid from the brain, but it does so in dramatic fashion. So anyone who looks at the data won't have anything to think about. It's very, very clear. What is unclear is whether that translates to any clinical benefit. Now, what happened was the company, in trying to eat their cake and have it, did what they call a futility analysis. Basically, they try to project the future. Are we wasting our time and money on this trial? And they decided they were, and then they pulled the plug on the study. But then they sat on the data, analyzed it, and decided that they had something, when in fact they did not. And so they got this approved, and the process by which this happened was a bit unseemly, and you may have seen some reports in the media about, some reports in the media about how that process played out. Anyway, so it's approved now. I am among those who are skeptical, but we understand this is the first thing that's been approved since 2003, specifically for Alzheimer's disease. That's a long time. That's a long time to wait. It's a lot of investment by everyone, professionals, advocates, people living with this disease. It was time for something to help. Now, initially, I was much more skeptical before than I am now, and the reason for that is that gantenerumab and lecanemab and donanemab, these things are hard to say, have promising data. They're around the pike. They're beginning to consider the time. It's just a matter of time before Eli Lilly and others file for compounds that have a similar mechanism of action and seem to have some promising data. So aducanumab is probably the first in its class, and the data that we voted down did not show that it failed. It showed that they hadn't made the case, and the recommendation was do another trial. But now that it's on the market, perhaps the FDA has said, do a trial as you do this, and then we can get a definitive answer. What I can say is that this has injected hope into the community. It has, and especially when you consider, as I mentioned, the other agents that are coming along. Should a person get an infusion, there are substantial risks. Okay, there are substantial risks. You may have seen in the New York Times just recently that there's the investigation of a death taking this medication. In the data, about 40% of people had radiological evidence of brain swelling or bleeding. About a quarter of those people had symptoms enough to consider stopping the drug. And I think about 10% of them actually did. Now, this is in a controlled clinical trial environment where that monitoring is secure. In the real world, we don't know how the monitoring will play out. Now, the final thing that I would mention is that Medicare has not yet ruled on this. At $56,000 a treatment or more, and that's not counting infusion centers and the labor for monitoring, it's going to be very expensive. It's not something at this point I would recommend anyone pay out of pocket for. So we'll have to see. Right now, I'm not encouraging people to seek it out, but if Medicare makes a ruling in favor of paying for it, then we'll have to rethink that.
Thank you so much. I know it's a very complex question to be asking of you.
And I know I went a little over time, but it's an important one.
It is. Thank you so much, Dr. Onyike, for all of the information that you shared with us today. I apologize to those who've put questions into the chat that we did not have time to address, but thank you, Dr. Onyike, for your time and for being with us for the second year in a row for our conference.
Thank you. Okay.
And so now, those of you who need a stretch break, please go ahead and take one, but we are going to keep rolling right into our next speaker. So our second session this morning is The Joy of Using Lego Serious Play in Caregiving by Loretta Veney. Loretta Woodward Veney is a 35-year security management professional who spent the first 15 years of her career managing security personnel before starting her own training company, offering topics including security management and operations, leadership, conflict resolution, and communication skills. In 2006, when Loretta's mom, Doris, was diagnosed with dementia, Loretta began learning everything she could about the disease and hoped to share that information so others could be more prepared for this devastating diagnosis than she had been. In 2013, that hope turned into Loretta's first book, Being My Mom's Mom, which highlights the first 6 years of the family's dementia journey. Loretta had the unwavering support of her husband, Tim, who did everything possible to be of help to Doris along this journey, and together they were Team Veney. By the middle of 2013, Loretta began receiving requests for presentations on her caregiver experience. And since that time, she has given more than 275 presentations and keynote addresses. In the summer of 2016, after almost 31 years of marriage, Tim died after a very brief illness while he and Loretta were traveling in New York. To help with her grief, Loretta took photos that she and Tim had taken over their many years of travel, added her motivational words to them, and compiled them into her second book called Refreshment for the Caregiver's Spirit. Loretta dedicated the book to Tim and hopes that it will inspire caregivers through tough days and long nights. Just this month, Robin Roberts from Good Morning America recognized Loretta Veney on the season finale of her Thriver Thursday series. How exciting and well-deserved for Loretta. So now we welcome Loretta to present the last session of our 35th Annual Caregivers Conference. Good morning, Loretta.
Good morning. Thank you, Lindsay and Steve, for having me. I really appreciate it. And I will do everything in my power to end on time. So I talk fast anyway, so I think that'll be really good. Let's see. And so we just have a couple of objectives for today. I'm going to tell you a little bit about how this whole love of Lego and joy and all that started. Tell you a little bit about the Lego Corporation and what Lego Serious Play actually is. Like, it's the #1 question I get all the time. And then I'm going to show you where all the joy comes from. So I've used it really successfully with caregivers. They were my first, I guess, interest, because we all work so hard as caregivers, so it was kind of a stress relief thing. And then I began working with those with dementia in all stages, and then quite by accident I started doing a joint session with care partners and the folks that they care for, care recipients. So show you a little bit about that. So the whole Lego thing, I think we all have hobbies that we love. And my mom bought me my first set of Lego bricks when I was about 5. I sort of remember that. But one of the things that always stuck was my mother taught us that we could be whatever we wanted and I could build whatever we wanted. And I believed that, and we did that. And what I learned about going even into my teenage years and my work years, we would always build and have a great time. But I also knew that that's where we talked out some really amazing stuff, things that were bothering us, grief, worry, even celebrating, things. And it's when my mom would open up the most. And so in 2006, when she was diagnosed, as Lindsay shared with you, she just kind of clammed up. Everybody's so, heartbroken over this diagnosis. But as soon as I would get the Legos out, she would start to open up and talk about how she was really feeling. And that was amazing. And so I kept doing that with her. It was our #1 activity. And it was, really amazing, her reaction to it. And because my mother taught us, when you find things that work in life, don't keep it to yourself, share it with other people. So that's how the whole thing, started. This is the picture in the Washington Post article. Everybody came to the house to see what we were doing and mom's reaction to it. And she was always so enthused by it. And sometimes, as she got into the middle stages of Alzheimer's, she would have that blank stare that we all, really hate. But as soon as you would get the Legos out, it was like she would come back. And so people's like, wow, look at how happy she is. And so that was, our joy. But then I started to share it with others. So just a little bit about Lego Serious Play. It's a Danish company. You might know that. It started in the 1930s, but it took Ole Kirk Christensen 3 years to find a name for it. He ended up with Lego, which is the combination of 2 words, leg and gut, which means play well. And in Latin, it means to put together. How about that? And so 2 really big things happened for it. They got a patent in 1958 with the current configuration for Lego bricks where they would stack on top of each other. And so that was pretty cool. And then in 1999, two very significant things that impacted me happened in 1999. The first thing that happened was they became the toy of the century. How about that? And then in 1999, in the middle of the year, they decided to spin off a group of people to help them examine how they could improve their own processes. Isn't that cool how somebody would think to do that? They wanted to be the best toy company in the world. They wanted to be the #1 toy company in the world. So they spun off this consultancy with people that had been in the company for 30 years, and Lego Serious Play was born. And they had one goal, and that was to take over Mattel, the Barbie people, as the #1 company. And as you can see on the left, in 2014, with the release of the first Lego movie, there have been many at this point, but the first one, that's what took them over the top. And so for the last 7 years, there's been a big battle between Mattel and Lego for being the #1 company in the world. But the reason I've been a lifelong Lego fan, I'm what they call an AFOL, which stands for Adult Fan of Lego, is that they have remained a family company. Yes, they have a big board with people whose last name is not Christensen, but the gentleman you're looking at on the screen there on the right, he is the 4th generation of Christensens in the company. I've been to Lego headquarters and right outside Copenhagen several times, and there's always a Christensen in the building somewhere. And so I always thought that's really cool to have a company that's that old, still with family members in it. And so by 2014, that's when my mother first didn't remember who I was, and that was obviously heartbreaking, but I wanted to take this Lego thing to the next level. So Lego Serious Play had become open source by then. You're looking at my class. It was one of the hardest classes I've ever taken, let me say that. And so I became a trained facilitator in Lego Serious Play. And then when COVID joined us, I got my online certification too. Who knew you could play with Legos online? But hey, it works. And I'm going to show you how in just a minute. And so what I have done with this facilitator training is to really connect with people in an amazing way. And so the goal of Lego Serious Play is in 4 parts. First, the facilitator, me, I pose a question or task, depending on what the group wants to accomplish. And then everybody builds, and then everybody shares the story of what they built. And then as the facilitator, I reflect on what I've seen and heard and what is happening in the group. It is a wonderful process. And the thing I want you to take away from it is this. It is what we call an equalizer, because once people come into the room or get on Zoom, everybody's equal. I've had the CEO all the way down to the janitorial staff or the coffee cart person, the food folks, and everybody's building and everybody is sharing. And it doesn't matter what your position is in the company. And that makes people a lot more willing to share and be open and honest, which is just the coolest thing ever. And so Lego Serious Play is all about the metaphors. See that green brick on the screen there? The green brick might just look like a green brick, but no. What if I were to tell you that it is a company looking to grow? Get it? Green, growing, you get it. Okay. So what I love about it is it helps us, in our imagination to transform what we're thinking into metaphors of whatever our story is that we're holding in our hand. So bricks become whatever folks tell us that they are. That's my favorite part. But what is so amazing is the power behind the story, and the listening part, listening to each other's stories is really one of the most amazing parts of the Lego Serious Play. And so I post a lot on social media. Some of you are likely friends of mine, and I've always made some Lego model, and I'm always putting it up, and I always relate it to caregivers. And this post in 2020 really got a lot of attention. It was during the lockdown when I couldn't see my mother who lives in a group home. And I made a model of me and mom looking at each other through the glass. And I have to tell you, that thing got a lot of response. And that's when I decided to dedicate 2021 to the year of the caregiver. So many people were upset about not being able to see loved ones or traveling and all this, and how much harder caregiving got when they were locked in and that kind of thing. So that's when I started to dedicate it. And so one of the things I did first was write some lesson plans for how I could assist professional and family caregivers. So On the left there, you see I've been helping folks with their strategic plans and their mission, how it's being carried out. Are there ways they could improve? I've been helping caregivers build joy and hope. Woohoo! We've been doing a lot of that, which you'll see. I work with a couple of organizations who are very realistic about the challenges that caregiving, really brings about for us. And so they wanted to embrace those challenges and find solutions. So we did that. I help people build their superpowers, their goals of some of the things they want to accomplish in their caregiving roles and responsibilities. And for the later stage, I also wanted to make sure I gave them the opportunity to have some art, and they don't even have to have a story. If they have a story, fine. And if not, it just looks pretty. And that is fabulous for me. So a variety of ways I've been able to reach caregivers, which is so cool. So the family caregiver group, this is one of a church support group, my church on Capitol Hill. And we got together on a Saturday and they were building to their little heart's content. And these are just advertisements for some of the things that I have done. Johns Hopkins is my largest partner, and we've been doing a lot over the summer with Lego Serious Play, and that's been really cool. And then just recently, last month, I did an in-person Building Joy and Memories with Sunrise of Silver Spring, Maryland. I'll show you more about that. Now, here is Lego Serious Play virtual style. And if you look at the picture on the left, what the top part of the grid captures is them building. So everybody's head is down and they only get 2 or 3 minutes to build. And they chose to build joy on that particular day. But then look at the bottom part of the grid. Everybody is watching intently the man in the middle on the right, who is describing what brings him joy. And his was related to his family, of course, and doing lots of family time. And you can see, look at this joy on people's faces. People are smiling and really intensely looking at what is being shared. And then on the right, another support group of Hopkins, they wanted to build hope. Several of them had written in that they had started to, lose some of their hope, and they wanted to do that. And you can see they were holding them up to the screen, and you can see some smiles in there as well. And so whatever it is they want to achieve, I try to do my best to pose the questions in such a way that they can get exactly what they want to get out of the session. Here's the Hilarity for Charity. I'm sure you've seen that. The actor Seth Rogen and his wife, Lauren Miller Rogen, her mother died of Alzheimer's a few years ago, and I'm on their care advisory board. And they were one of the groups, there have been several, but they were one of the groups who wanted to embrace caregiver challenges. And I'm going to say more about this picture in a bit, particularly about the middle of the grid where there's a whole family of people, and they helped me uncover something I had not anticipated. And what is really amazing about the grid on the right, the woman at the very top on the right, Lily Lou, whose name I believe you can see, she and I have communicated so much afterwards. She continues, because they get to keep the bricks, she has continued to find hope, and she continues to rebuild her model based on how she's feeling at the time. So she went well beyond the session. And so not only can you find joy and build joy, hey, you can keep doing it too. So that's pretty neat. The largest family sort of caregiver event thing I've done, 21 people. We had people in a private home, in the dining room, in the living room, and on Zoom. It's so a lot of joy. Look at the smiles of those folks. And it was, I was very proud of this one, because with COVID, we kept people as segregated as we could, but they still got the joy out of it. And the living room people only came into the dining room to hold it up to the camera so the people on Zoom could see. So as you can see, there are a variety of things that you can do to reach all the people you really want to reach. And I think that is so amazing. So on the professional end, I've reached almost everybody: assisted living, memory care, social workers, CNAs, OTs. That group is Generations Crossing in Harrisonburg, right down from James Madison University. I've done a lot of work for them. And there are OTs on the left there from Fairfax. And they were, building better solutions, that kind of thing. That was really cool to work with the young people that they were working with. And then the Harrisonburg group, they have a intergenerational program there. So we were building, better teams and making sure we can reach both the young people, pre-K, and the adults with dementia because they share the same building, and they want to make sure they're achieving the mission together. So very nice way to interact. This is just more photos of them, but I really want you to see the smiles, the focus, the listening. There are three gentlemen who work in the pre-K, first, second grades classes there. And the lady on the bottom right, she may appear to be writing while people are talking, but the group was so large, I had a leader at each table who was capturing the stories of each person. And at the end of the session, I typed up everything that people had shared because they wanted to revisit it. But if you just look at the focus of the people and how much fun everybody's having, the middle picture with the woman in the purple and the blue sweater, they're mother and daughter. And what was so amazing about what they built is they were pretty similar, and they were not even in the same groups when they were building. So it was stunning how much alike that they were. So many things can come out of it, and so much joy as well. Now, what about the folks with dementia? In the early stage, I have them build their bucket list. There's still a lot of things they want to accomplish, and I don't want to minimize that in any way. So we go for it with the little bucket list. What we're doing right now is focusing on a lot of holidays coming up, their favorite memory of holidays, and you would be stunned by how much comes out of that, how positive they are, how much they can remember, especially about the 1930s and 40s, the favorite gift they got. Very interesting when I have them build home, because you know how much they all want to go home, and they have done some amazing things. What they remember about the home they grew up in or where they raised their children, amazing. And as I mentioned in the late stage, I'm not going to leave them out. So we do Lego art, and like I said, we can have discussion, but if they don't know what they built, we just clap and move on. And so it's just really about having fun and not really about the story by the time they get to the late stage. But check this out. This is one of the most fascinating things I think I've done with late stage folks, because you just uncover so many things. There's the woman in the brightly colored jacket at the top part of that picture. She stacked them all up, and her colors were just so mixed and bright, and really captured a lot of what she was in real life. She loved bright colors. She always was very much into fashion and all that. And so we just had a ton of fun. But what I really want you to see is the picture on the right. There's an orange arrow pointing down to that. If you know anything about Legos, I want you to notice that that piece of artwork is upside down. Usually the Lego studs are on top. That one is turned upside down. I've never seen anybody do that. So I say to the wonderful woman that built it, "Hey, yours is upside down. That is so cool." She looks at me like if I was crazy. So she says, "Well, of course it's upside down. It's just like my brain." How's that? Right? This is why I do that, because you cover all kinds of. I found out later she had been a teacher at a professor at the University of Maryland in physics for like 30 some years, and wow, look at how her brain was still processing. I think it was one of the most stunning things that's ever happened. This is the Harrisonburg Adult Day Group. And again, look at the joy on their faces. I'm going to say something about the couple at the top on the left, because they are one of the reasons I started having them build together as a team. But what I will share right now is that he has Parkinson's, and so he really can't move the Legos around like he used to. So she has to come on Lego Day and be his partner. So I'm going to say more about that. And the picture on the far right, we were building a world without Alzheimer's. We spent the entire day doing it. And we brought them out one or two at a time so they wouldn't get too overwhelmed. And just look, as they rolled around the table, they looked at what they had contributed. And I want you to look at all the white pieces that are in the center of that structure. And Lego makes a block called architecture, and I'll tell you why we use the white pieces and what we used it for in just a minute. The folks who care for people, I think, I had focused on them, and I had focused on the people with dementia, but I had never put the two of them together, and it happened accidentally. And I won't go into the whole story because we're going to be short of time. However, what I will say is that it came about as an accident where somebody who was observing the session with dementia ended up starting to build something with his wife sitting there. She was supposed to be her session. And, he reached in and grabbed the Legos, and it was an amazing scene because he didn't do any activities, and he was pretty behavior-wise, he was pretty challenging. And rather than cancel, she brought him to the session with her, and he created a whole new thing. And so she was everybody in the room, on Zoom was crying because he never did any activities, and his behavior had gotten so bad that they were trying to convince her to put him in, a memory care facility. And that day, the Lego bricks just transformed him. And like I said, I didn't know the backstory, so everybody was crying but me. And so it was stunning. Look at the picture on the left. I know it's not a great picture. Their internet was very unstable, but they brought the whole family. There's grandma sitting in the middle, the third person. And what you can't see is the 10-year-old on the end. You see her hands. And they were the Embracing Caregiver Challenges group. And each one of them built and shared, but that 10-year-old stole the show. When they were asked to build what was their greatest challenge, she built this wall saying she couldn't find the right words to really talk to grandma. And so how are you going to embrace the challenge? She knocked that wall down and said she was going to sit right next to grandma and look in her eyes so they could communicate. And I was like, wow. And she was 10 years old. And there's the couple at work. The gentleman with Parkinson is in addition to dementia, and they always work as a team, and they had a strategy of what they wanted to build, and together they achieved it. And then the couple on the right was two of my best friends. It was the week that the gentleman in the picture, Crane, decided he didn't want to do chemo anymore after 20 years of prostate cancer. And so that was the happiest I think I had ever seen them once he made that decision. He lived about another month or so, but they had a fabulous time, and we just hugged and did all that stuff. And he said the Legos just transformed him, and I appreciated that. And this was the sunrise event, and we were building memories, and that was a fabulous event. And you see, we all have our masks on. The tables were totally separated. Only the family sat together. And two people did have relatives were supposed to come, but something came up and they couldn't. So Sunrise was nice enough to have a staff member sit at the table with them. But look at the picture in the left-hand side of the grid. There's an entire family holding on to the bricks. And that picture wasn't staged at all. They were building their favorite vacation. And it was the woman with dementias, her back is to you, and then her niece is on the right, and niece's husband's on the left, on the other side of the table. And they were building the cruise ship for the cruise they went on 17 years ago. And while they were building, the woman reveals that, they were line dancing, and the niece started crying. You remember that, Auntie? And she said, of course I remember. And then she talked about the midnight buffet. I mean, the whole room was, in tears. But again, you can uncover so many things. You're not going to think about that cruise you went on unless we're building something very focused. People built, their favorite base in the military. And thank you for all our veterans today. You can see the bottom left grid. There's a young man from Sunrise with the white mask, and he's helping a couple that had been married 52 years build their marriage and the joy of their marriage. And so just a wonderful amount of things that can come out of it. And so I'm just all about the joy for them. Here's that intergenerational group building with the white pieces. So I guess some of their funding for this program is based on how many intergenerational things they do. So the reason we use the all white pieces was that it would be easy to identify which parts of that huge model we built were done by the intergenerational group. So look at them go. That was pretty cool. That was a lot of fun. You see me with all my little white hair on the right-hand side. And so, I try to always focus on what's working, what makes people happy, and how we can get joy from that. And that was the end of the day. As you can see, the beginning of the day, we started with just the flat Lego panels, the studs, all ready for stuff. And as the day progressed, it got bigger and bigger and bigger. And I think, like I said, I've done a lot of work with them, but I've been trying to work with these days support groups and everybody that wants to find joy or new ways to do things or better strategies for caregiving. Whatever it is they tell me they want to accomplish, I build the questions. And typically in a 2-hour session, we usually can do 3 rounds of building. So I start with what takes your joy, and then what brings you joy, and how they're going to maintain it, throughout 2022 and that kind of thing. So that's how it's really set up, and we can get so much done, in a day. session. So I've learned a few lessons as we're in our last minute. There's not a lot of research at all on the impact of those with dementia using the Lego bricks. As one article I found out of the UK. I'm actually going to go to the UK and meet with some of my Lego friends over there who work in care homes. I have been stunned with the power of the 3D models that you're actually holding in your hand. I mean, when people built what COVID had stolen from them. People cried, and when you're looking at, you couldn't go to the gym or you couldn't travel or all these things, feelings that they were having, or mama's adult daycare program was closed and all those kind of things. So all of that can come out with this method. Unlocking memories brings about a lot of surprises, a whole lot of joy, but some surprises too. And I told you about the cruise ship building and all of that. So you never know what a person's going to say. Maybe they remember building with their grandchildren or their kids when they were little. And so I'm going to take those surprises and keep moving on. So that's why my last lesson I've learned from doing this work for the last, I've been certified, as I said, since 2014, but really the last 2 or 3 years, I've been really into that, as my posts on social media indicate. So I think that the future is really bright, and I'm looking forward to what's coming next with joy of using Lego bricks with folks with dementia. So thank you. I did end like right on time. So I hope I did it some justice.
Loretta, you're amazing. All right, we have 3 questions that have come in. So we're going to take these 3. Okay. 2 of them are specifically about the Legos. So the first question, are there specific Lego sets for serious play, or do you just use any Legos?
Great question. So Lego makes a sealed pack of bricks very similar to this. This is my pack that I built. If you look carefully, you can see a heart. There's a pink Lego heart in there. And because I wanted to show the love between, the caregivers need and give as part of caregiving. But yes, for trained facilitators, if you get on the Lego website, there are sealed packs. I've just started making mine. I call mine inspiration kits. I would suggest if someone wants to use it at home with their loved ones, they just go to Target or Walmart or whomever and just get a small box. You don't need, a whole lot. And you want to get some of the larger, pieces. You don't have to get the Duplos. My mother can do both, but get something small to see, how they'll take with it. But yes, to answer the question, there are some specific ones, but you don't need that to have a very successful playtime with them. It's a lot of fun.
Okay, and I mean, you basically just answered my second question, which was, what size Legos do you use? Some look small. Do you ever have a problem with small Legos? Do you use Duplos?
Yes.
But you just
so the Duplos do work. I have pictures of my mom using both that I put on social media all the time. She at 92 still has lots of dexterity to do that, but some of them don't. So if your person is in the middle to late stages, I would go with the Duplos. And you can go to Walmart or Target and just get a very small box. I think like $24 on Amazon and Walmart and Target in that range. There's a $16 box too, I believe on Amazon that it has just a little small storage box. And there's plenty in there too, the 80 pieces, I think, in that box. And that's way more than you probably need. And it can lead to lots of fun. So that's the answer to the Duplos. But yes, you have to, and I always send instructions with my kids, and I always say, if you're going to be doing it together, don't let them use this unattended, because yes, there's a round piece in particular that looks very much like a pill. So you definitely don't want them to put it in their mouth or anything like that. And I have a friend, a neighbor, who helps me sort. So whenever I'm going to do something with folks with dementia, we take all the small pieces out before I go wherever I'm going. Yeah.
All right, wonderful. And the last question, do you think it's more about the Legos or about spending quality time with the individual?
That's a great question. I would say both in a way. The quality time is sure, because in my case, it helped my mother communicate more effectively. And when she would climb up, I'd get the Legos out. And that's why I continued to use them as an adult. So the quality time is cool. And that's why it doesn't matter what they build. I'm going to cheer for whatever it is you do. So yeah, and I always say to people when I'm doing my activity, I have a presentation called Engaging Activities for Every Alzheimer's Stage. And in that, I talk about how it's important just to let them do it. Don't correct them. No, mama, you don't do it that way. No, it doesn't matter how they do it. Just have some fun. So I would say the same thing about the Legos. Yeah, and in my case, it's just a selfish thing. That's my only connection with her. She, she just looks around and, but when you put the Legos in front of her, she, comes back. And I focus on that because I want her to be able to do that for as long as possible. So.
All right, lovely. Thank you so much to Loretta. Wonderful, fast moving presentation, lots of great information, lots of great inspiration for all of us. So I really appreciate you. And I want to let everyone know that a few minutes ago, I did put Loretta's website in the chat.
Yes.
So if you want to learn more about Loretta, you want to get in touch with Loretta, it's lorettaveney.com. And it's in
yes,
the chat.
Indeed.
So.
And I'm happy to, answer any other questions that you may have. But again, the thing is just to get it out there with people learning from each other and having fun, at the same time. I think that is so important.
Actually, Lindsay, the next thing we've got coming up is we're going to be giving away some books. And one of the books is Loretta's book. Loretta, do you want to tell folks just a brief overview of Being My Mom's Mom and what that book is about?
Sure, the title kind of speaks for itself. So it's the whole role reversal thing, and it focuses on 4 primary things: forgiveness and patience, preparation and hope. And so you need a lot of patience, particularly with this disease, with the repetition and all that, and forgiveness for all the things they say, or forgiving yourselves for not being able to do everything in the same day. And so, but I think the biggest thing is really the preparation. How do you prepare for this disease and the financial impact and all those kinds of things? And then I absolutely try to leave people with hope. So those are the 4 tenets of Being My Mom's Mom, but the title came from her.
Excellent. Love it.
Thank you so much, Loretta. And I'm going to invite our chairperson, Juliana, back onto the screen and my other consortium colleagues to wrap us up with the conference today. So thank you, everyone.
Thank you so much, Lindsay, and thank you to both of our presenters. Wow, that was such a great way to kind of finish our conference. But before we actually end today's sessions, let's take a moment to spin for prizes. Today, we're going to be giving away 3 copies of Keeping Love Alive as Memories Fade, written by Dr. Gary Chapman, Dr. Edward Shaw, and Debbie Barr. We had them present on our first session, and we're also going to be giving away a copy of Caregiving at a Glance, a publication from Insight Memory Care Center, and 2 copies of Being My Mom's Mom by Loretta Veney, who just presented. Now I would like to welcome my consortium member, Amber. Welcome, Amber.
Hi, Juliana. All right, for the first door prize will go with Keeping Love Alive as Memories Fade from our speakers on Tuesday. Let's see who the lucky winner is. We're going to give 3 copies of this away.
That's
Trina Webb. I know Trina.
Yeah, right.
Congratulations, Trina. All right, next will be Being My Mom's Mom. Let's see who we have.
Tiana Ward.
Tiana Ward. Congratulations, Tiana. And we're giving 1 copy of Caregiving at a Glance, a publication from Insight Memory Care Center. Who's the lucky winner today?
Jose
Acosta. All right, and we'll go back and do another copy of Keeping Memories Alive, or Keeping Love Alive as Memories Fade.
Stephanie Craddock.
Congratulations, Stephanie. Next is the 2nd copy of Loretta Veney's book, Being My Mom's Mom.
Hey, Robin Weissman.
Congratulations, Robin. And the last prize for the day will be the last copy of Keeping Love Alive as Memories Fade. And I want to thank our authors for donating the door prizes to us.
Levita Strickland.
Levita Strickland. All right, so we will be in touch if we don't have your address and make sure that we get copies to you.
Thank you so much, Amber and Steve, and congratulations to our lucky winner. So as mentioned, these books are going to be mailed by the authors to the addresses that you provided during registration. And if you haven't provided an address, like Amber said, we are going to be in touch with you via email. Thank you so much. Next slide, Steve.
Okay, let's see here.
Now, I would like to give everyone one last reminder to visit our virtual exhibit hall to explore some of our local resources in Northern Virginia. Also, if you want to learn more about our wonderful sponsors, this is a great place to do that. We are also going to paste the link in the chat box so that you can have that and access it at any time. And like I said before, the exhibit hall is going to be available 24/7 for the entire month of November and December. And we really want to hear about your conference experience. We are going to be putting a link in the chat box to a SurveyMonkey evaluation for the entire conference. Please share your feedback. Although this is our 35th annual Caregivers Conference, it was our second virtual Caregivers Conference. And we want to know what this event was like for you. What were the most valuable aspects of the conference? What would you like to learn about next year? Let us know. We'll also be sending a post-conference email at the end of today, which will include the link to the evaluation as well. And for those professionals, George Mason University reviewed and approved our program, Caregiving as Memories Fade, for 0.6 CEUs, which means 6 instruction hours. So please follow the link that we are going to put in the chat right now if you want to apply to CEUs after you have successfully completed this program. This link is going to be included in the post-conference email as well. So please stay tuned for that email. And the CEUs is provided by George Mason University for a fee of $50. Now, if you do not need an official CEU, but do want a general certificate of attendance for this week's conference, we are going to be including a PDF of a certificate in our post-conference email. And I also want to remind you to visit our website where you can find all of our handouts for our conference sessions, as well as the speaker bios, as well as our virtual hall and many more information. Next slide, please. So as we wrap up this year's conference, I want to recognize the time and effort that it took for all of you to be here. Learning takes time and commitment, and adapting to your role and loved one needs isn't always easy. And thriving might seem challenging and at times impossible, but you are here and we are grateful and confident that you are leaving the conference with enlightening information, innovative approaches to connect with your loved ones, and helpful resources to help you on your journey. We hope that this carries you through the holiday season with hope and positivity. Thanks to everyone for joining us for our 35th annual NVDCC Caregivers Conference, and we hope that you will join us next year for our 36th Caregivers Conference. And until then, be well, everyone.